After 6 years of treatment with a colleague, this is Will's situation. Come on, 6 years! He's a fantastic boy, but he was tired of seeing no improvements in his treatment. So he came to my office, hoping for some answers. And this is one of the situations where you should just say, we can't really accept new patients, we're kind of busy at the moment. Here's the number of a sworn enemy of mine, call him. But no, I had to break my nose against it. It looks like the colleague has tried to disimpact those canines, but he's had some sort of obstacle. He was disimpacting the canines on a light round wire, and he's been losing anchorage. There is a lateral open bite. With non-self-ligating techniques, it is pretty important to have a rectangular steel wire as anchorage while disimpacting canines. We just need some more anchorage to solve the case. Here we go. So I asked the patient to bring me back his x-rays, and this is what I get. Obviously, there was a problem with those canines. You can make a pretty good guess of the chances that a canine has to remain impacted in the bone at around age 10 by looking at how inclined and far away from the midline the canine is on the panoramic. But we are way beyond those speculations now, as these canines are impacted and we have to figure out a way to bring them out. After 6 years of treatment and a questionable biomechanics, I debond everything and prescribe an oral hygiene. 6 months after debonding, I'm glad to see there is some relapse in the lateral open bites, which have closed up a bit. Oral hygiene conditions are okay, except for the fungi colony growing on the eyelids. Well, the time has come to see with a cone beam where those canines are. And here it is. No good news from the cone beam. Look at that. The upper right canine has completely wiped out the lateral incisors root. I touched 12 and it's got a type 1 mobility. And considering the fact that I will probably worsen its root conditions while trying to bring down that canine, I decide to extract it. Well, the idea here is to take advantage of the second-class occlusion and to bring forward the molars and bicuspids. So, we will have the first premolar in the canine's place, and we'll just bring the canine out to the lateral incisors place. I would then just take a burst and reduce its cuspid a little bit, and it will be just fine, looking more or less like a lateral incisor. I almost got a heart attack when I saw the patient a month and a half later. The canine's ankylosis had canted the whole upper arch, and extracting the lateral incisor has been a hell of a bad idea as it cannot be replaced by the ankylosed canine. I took an irreversible decision before considering all the possible outcomes. And now what? After trying luxation, I surrendered to the idea that tooth will not come out. The open bite on the right side relapsed back a bit, and on the other side, the canine was coming down, so I waited to have an acceptable disimpaction at least on one side. After a delicate talk with the patient and his parents to explain them the situation, we planned to bond a Maryland bridge to replace the tooth I had extracted and to reshape the first bicuspid to make it look like a canine. At this point, I have to admit, there was not much left to do, so I ended up Will's occlusion in this questionable way. And here he is, with his final panoramic showing the canine with its eyelet included in the bone and a mini screw I have used to try to bring the canine backward. There is no way of recognizing an ankylosed tooth from a radiograph, but when you see these hook-shaped apexes, pay attention. That tooth could make a fool of you. It surely made a fool of me. Now, take a look at those incisors' roots. We've had resorption, as Will has undergone a total of 7 years of orthodontic treatment. It's almost like a mortgage. Now, we know that the risk of root resorption is proportional to treatment time, and the stronger the forces we use, the greater the risk. this is the result. But leaving aside all these dreadful clinical considerations, Will's ankylosis has taught me a lot of things. One of them is to carefully evaluate cases that other colleagues had found difficult to solve. Also, from now on, I swear I will always check if a tooth is ankylosed before taking any irreversible action. In the next video, I'll show you how to deal with impacted canines before even having to put braces on.